When we picture a woman who is pregnant, we often picture her from a variety of different experiences. She can be rich, she can be poor, young or old, but oftentimes we picture an abled woman as a woman who's pregnant, and pregnancy is not something that we picture for someone who's disabled. Our team was looking at gaps in maternity care for the differently abled, and we found that even though pregnancy is one of the most statistically normal biomedical events that someone with a uterus can experience, for disabled women, this is often treated as an anomaly. 1 in 4 women have a disability in the US, and 10 to 12% of women from a childbearing age have a disability. And even though disabled women get pregnant and give birth at the same rate as abled women, care and health outcomes for this segment are drastically different. So if you look at health outcomes, there is a 29% higher maternal morbidity rate for this group. And we see an increased risk of complications, not because of the disability, but a result of not getting appropriate care. We looked at understanding the gaps across the social determinants, and we saw that there was a lot of inequities in terms of getting access to education, the quality of information that's available, building communities, and healthy environments. So here is Emma. She has a rare autoimmune disease that had where she endured a spinal cord injury at the age of 10, and she's been in a wheelchair ever since. So when she finds out that she's pregnant, this is a joyous moment for her, but she goes to an OBGYN that a friend recommends, and she is labeled as a liability and refused care. So now it's in Emma's hands to sort of become an advocate for herself, find the right provider, find the information, and prepare for delivery. Her labor and delivery is also not without complications. She has a C-section. And postpartum, it's hard for her to find the right resources and care for herself and her newborn. Emma's not alone. From our research, we found that almost all women suffering with disabilities have a really hard time finding community and connecting with other women who have gone through the same thing that they have. Also, the resources that are available to them are usually they're the same resources that able-bodied women get. And as this person writes here, everyone wrote me off, so I wrote myself off as well. There is a lot of anxiety, and they feel that clinicians were less knowledgeable about their specific disability than they would have preferred. They experience a lot of loneliness. There's a lot of negative stereotypes associated with disabilities, and so they're reluctant to ask questions and seek care at the right time. And also, because they don't have adequate information about how a disability can affect their pregnancy, there's a lot of fear. Also, in terms of complications, this group is at a higher risk for adverse maternal outcomes. During pregnancy, during labor and delivery, and also postpartum, there's a risk for complications. So we looked at how we could create impact and what are the opportunities to help this group. Obviously, by early intervention, we have the opportunity to reduce mortality rates in this group. By intervening early and even before someone gets pregnant, we have the opportunities to set up a course of action for how that pregnancy could turn out. Also, there's a better awareness that we could create by talking to these women early on and giving them the right resources. And we can also reduce the number of emergency room visits. We found that in this group, women tend to visit the emergency room almost 12 times more than abled women during their pregnancy. So we looked at how we could inform and foster inclusive environments for pregnant women with disabilities to create systemic changes in their healthcare. So our service is really looking at a two-pronged approach. We're looking at something that will target the patient as well as the provider. We want to create a community for pregnant women with disabilities where they can share some of their anxieties, get feedback from providers, and also connect with other women who are sort of going through the same thing that they are. And also from the provider end, we found that there is a lot of lack of knowledge. And so we want to collect all this data because there is so little data about this group. So we can create standard practice guides. And by having this two-pronged approach, we're able to connect this group of people with all the different resources and tools that they can use to have a successful pregnancy. So like I mentioned earlier, we want to help patients find the right provider. We want to give patients the access to resources because it's hard for them to, usually what people do is they'll look online and it's not really a credible source. We want to build communities. And the provider will get a standard practice guide that will be made by collecting data on this group. So we'll have evidence-based outcomes for how to deal with different disabilities. There we see like a huge need. In a survey conducted by Dr. Liz Lazzoni and Amy Wint, all women with disabilities expressed a need for better information to guide them through their pregnancy so they can make critical decisions about their delivery. And also from a provider end, there's a huge need to have more information because we found that 1/5 of OBGYNs, less than 1/5, actually receive training on care for women with disabilities. So the impact of sort of giving them access to information, creating that awareness means that we'll have decreased complications during pregnancy, labor and delivery, and postpartum. We're also giving clinicians better guidelines and practices to follow so that the care is equal amongst all these groups. And how can we measure this impact over the next 5 years? We can look at the number of emergency visits in this group, the number of pregnancy-related health complications, and the prevalence and development of preventable health conditions during pregnancy. As I mentioned, this is quite a big market size where we have 36 million women with disabilities, and 10 to 12% of that's around 6 million have disabilities of childbearing age. And we decided to look at women with mobility disabilities as a focal set, and there's around 720,000 women who are of childbearing age with mobility disabilities. So early access to care, again, means reduced costs. These are just some of the costs associated with complications during pregnancy versus what it costs for like a healthy delivery. Some of the costs that we have is to set up a hosting platform, collecting the data, designing this platform, preparing resource guides, implementing the framework across different clinics, and then outreach. So from the data, if we consider 5% of our demographic, we're able to triage this patient to the right OBGYN and reduce 10% of the cost due to complications, we can save approximately 36 million. Some of our strategies to bring this to life is first to identify a target user group. So we'll be looking at women with mobility disabilities first because they're the most prevalent. We can ask these women what they'd like to see, collect data, design this platform, adopt this framework across different clinics, and then have a pilot test to get insights from real women and make iterations. And then pre-launch, we can curate participating hospitals. We'll be able to see where this framework will be adopted, launch our website and resource guides, and then market the product. So pregnancy can be a really stressful time, even for like an able-bodied person who has a healthy delivery. For disabled women, this can be even more stressful. So we're here to sort of help alleviate that stress and create a positive experience. This is our team, and thank you so much.
To make sure I understand what it is a patient-facing platform where they have a group that I assume someone would kind of watch or curate so they can share.
Yeah, exactly.
And then a guide for providers to go to.
Curating the right information for these patients so that they feel more at ease, because there's this huge lack of information for them because all the resources that they get are aimed at able-bodied women. And then from the provider's end, we notice that there's like a huge lack of data because not many times this data isn't categorized or collated anywhere. So we want to essentially create a repository of data and then use that data to sort of form the standard practice guide.
So it seems that it's self-service. There's not a care coordination advocate.
No, right now, for now, this is just sort of the initial service idea that we have. And obviously this can be scaled up for other disabilities. We're looking at mobility disabilities first. This is looking at maternal services. There's also the same gap in access to reproductive care for this group. So there's lots of ways that this can sort of be scaled up.
Is anybody paying for anything here, or is this a free resource for patients and providers?
We're looking at this to be like a free resource for patients and providers, yes, because we'll be saving costs just by intervening early, and that's really the way we're assuming this would work, yeah.
So how would it be funded?
We see that like from the amount that we're saving in their complications, if that money is sort of put into developing this, it is self-serving.
Whose money are you saving?
If so, a person from the insurance company where all of these expenses are essentially going to be paid. When we sort of put in the costs that we're saving into developing this platform and these resource guides, it's sort of a self-serving platform.
It seems if you do this in the early pilot stages, you probably want to pick a city where the patients and the providers in that system are aligned. I'm trying to think about how it scales if the people aren't necessarily where the aligned health facilities are, and how you, in the early stage, keep them synchronized, because if you're really dependent on those two halves of the model working together, if they're in disparate places, then you're going to have a lot of frustrated people.
Right. You're right. And we sort of wanted, when we looked at some of the ways this could go, there are a lot of initiatives locally in terms of there's lots of gaps in access to care. There's lack in like transportation. There's lacks in midwife services. So essentially this resource guide is just sort of summarizing what someone can access in their community and then sort of connecting with them. But right now we see that there's a gap because women are unable to find that information locally online, and it's basically causing them to receive care at a later stage where there's a higher risk for complications to be developed.